Administration. Abid, we are back to you.
Okay, Ahmad. Yeah, by the way. Ahmad?
Yes, we are hearing you.
Did you see the fluoroscopy image?
Not yet.
No?
We do see the endoscopic image now of your sphincterotome.
So what do you think the endoscopy image? Is it Olympus or something else?
No, this is something fancy.
So this is the first time to use the disposable duodenoscope. This is from Ambu. So you see the screen, and there is a lot of features on the screen. So the same patient we did, me and Khalid, the FNA, we decided to do the ERCP and then to perform the procedure with the disposable duodenoscope. As you see, it's almost similar to the standard duodenoscope. I'm not sure did you have the X-ray. The good things you see the shape of the wires of the duodenoscope. So now I'm cannulating the papilla. I'm using the clever cut from Olympus. So
the new concept of disposable duodenoscopes
totally
actually has been a main shift to the care we're providing endoscopically for those who are in need. What's your take, Mike, on this? I mean, Dr. Omar as well. Anything that you would like to say about that?
So, Ahmad, easy cannulations with the sphincterotome. Now I'm using the clever cut from Olympus. So as you see, the sphincterotome is already covered. Now we are cannulated the papilla. Now we'll inject. Can you inject, please?
So Abid, what was the cannulation any different from the conventional ERCP scopes we're using usually? Did you find it like stiffer, difficult to control? The elevator did not work well?
There's no big difference, but seems to be a plastic scope. That's why you have to be stressing on the wheels, and you have to put the positions in the right all the time. So what we have in the market now, we have the Ambu and we have the XLD. So there are minor difference between the two companies. I think the one I'm using now is more flexible. Maybe sometimes you can perform the entire procedure. For very advanced procedure like cholangioscopy or spyglass may be difficult. So the XLD, it's almost more stiff and more stable sometimes than the DNM. Now, as you see, I'm pushing the sphincterotome inside. So inject please for me, guys. So I think we are having long structure, as you see there. Is it in the it's in the hilar? So most likely this patient is a cholangiocarcinoma. So we are performing now the good cholangiogram. So we try to do the sphincterotomy now. Can you advance the wire up, please? Wire up, please. Yeah, wire up.
I have a question here. If you guys
yes. Okay.
Allah يعطيك العافية دكتور عابس جنان. So for the Ambu disposable ERCP scopes.
Can you bring the mic closer, please?
For the
yes,
for the
excellent.
Ambu disposable scopes, you don't notice, I think I agree with you, slightly more stiffer than the usual duodenoscopes. And then my other question in the future, when we actually have it available and readily, will you be selecting like your patient maybe with like multi-resistant organisms, or which patients are you going to focus on using those disposable scopes on?
So Abid, I don't believe that you heard this question, but it has been a long debate. So the audience is asking, now, since we are in the era of disposable duodenoscopes, and this is likely going to be much more available in many centers to come. Now, the question is, would you do it as a regular endoscopic ERCP device in every single case, or are you going to be more selective in choosing the proper patients, such as immune compromised and those in immune and chemotherapies, and that's it?
Yes.
So what's your take on this?
Relax, please. One of the challenging issue with these disposable duodenoscope is, mainly is the price. That's number one. Number two, it will be very difficult to be used with the high volume centers. If you're performing 7 procedures per day, it's very costly. So, and I agree with you totally. I agree with the comment. Usually, we have very selective cases. I can tell you what happened to sometimes for us, we are run out of material to clean our scope or sterilization you can use. Or if you have a patient, very high infectious patient, you can do it. Or maybe something overnight. So there are some of indication, but in daily practice, in very high volume center, I think it's very difficult to implement all at the long 12 centimeter stent.
Yeah, that's true.
That's-
So
yeah.
it's
Yeah.
a long debate, but to make it short, I mean, it's only indicated, or we try to make it as indicated for those who are immune compromised and at risk of acquiring multi-drug resistant bacterial infections, which would make their care worse. So it seems like we
Ahmad,
have
do you have
another.
the cholangiogram?
What's that?
Do you have the?
Come again, Abid?
Do you have the cholangiogram image or picture?
We have the fluoro and the endoscopy.
What do you think?
So there's one nice feature I think we all appreciate is that the scope, much of the metallic material at the end of the scope is removed. You just see some of the guiding and flexion wires. So I think normally you'd have a blind spot behind your scope, but we can actually see behind it. So it's a nice unique feature of this scope.
I echo that, really. Sometimes it can be a small stone hidden there and it cannot really comment in the area behind the scope. But yes, that's absolutely correct. So Abid, we see you, we see the endoscopic image and the fluoroscopic image.
So Ahmad, what do you think is the left system is
Well,
is enough
that's, yeah, just looking at the fluoroscopy and the cholangiogram, clearly we do have a normal common bile duct, and then we can see a long structure extending throughout the common hepatic duct, and then we see the significantly dilated left hepatic system, and I can see a start of the filling in the right system. This wire seems to be going into the right posterior branch.
I agree with you. Yeah, that's why I want to be in the main. So that's why I told her you can wait for the stent. Yes. What do you think, Turki?
So Abid, now how almost the right system is obliterated.
Okay.
Do you want to place a stent in the left
By the
side?
way,
Do
one
you
more
try
comment.
the other side to duplicate?
Yes.
Yes,
So,
by all means.
One point of debate is also sustainability and green, and we want to be all greener and greener. So there's a nice study from Heiko Pohl from the US extrapolating the numbers. Just for the US, we have 18 millions of single-use endoscopes per year, so annually. So I think that's also a critical point to think about recycling things.
Or balloon.
It really gives me a
No,
gut
no,
feeling
no, exactly
to throw away in the trash a perfect
Yeah.
functional endoscope. So I think that's also a point of discussion.
That's a great point.
So Ahmad, Turkey, Dr. Turki Alamari with me is just trying to say, you just cannulate and stent the left system and then try to with the right system.
Sure.
Do you think this is okay, or you can drain only the left system? Or
So the good things, I mean, you can just, you know better as well. The good thing about having cholangioscope, I mean, the challenge that you would see with clad skin cholangiocarcinomas, if you drain one side, you may lift up with the other side not draining well, which would risk the patient to have a cholangitis after ERCP, or even risk the liver tissue to be atrophic. So the good thing about, definitely you need to drain both. Definitely you may need to stent both. Now the thing about cholangioscopy, it can selectively, if you manage to push it through the stricture, wire both branches, which will have a higher success rate in draining both and stenting both. And that's on top of the tissue acquisition and diagnosis. So are we...
Okay, Ahmad, I think we are done with the procedure. We'll next step, try to insert a long stent, plastic,
Okay.
12 centimeter and 7 French or 15. And then we hope it can help the patient draining the entire liver or left system. And eventually, maybe he needs the subsequent ERCP once confirmed as the malignant, and then to be putting the permanent stent.
Thank
or,
you, Abid.
right
I think,
system. Okay?
Mike, I think in this case, he is not even a candidate for resection, given that he has a locally advanced disease with the lymph nodes we have seen. I would aim for palliative stenting and making sure I drain both ducts, because what really, let's say, what is troublesome to the cholangiocarcinoma patients is not actually the disease or the tumor itself as much as the cholangitis and the recurrent hospital admissions they get. As long as you get good drainage of the bile ducts, those patients can remain home for years. I have cholangiocarcinoma patients that I'm still following it in my clinic for the last 4 years.